we have three distinguished panelists. Dr. Karanassos is a specialist in OCT, so please for your comments and questions.
Thank you, Mr. Chairman. I'm not sure. Okay. So actually, we had 4 great talks today. The first one actually summarized what has been established for intravascular imaging. So what is the indication for which we already have the data in order to say that we should perform it. The next couple of presentations actually saw 2 additional indications. They are great indications. We all do it in clinical practice, but we do not know yet if we can change the outcome. And of course, the 4th presentation by Chris was an excellent presentation, an excellent summary of what has been said. So I would like to stand mostly on the 3rd presentation. One of the holy grails of interventional cardiology has always been trying to identify the plaque that is going to give you an event. And we already have 3 large studies with VH, 3 studies with NIRS, and 1 study with OCT, all showing that having a high-risk plaque by intravascular imaging has a prognostic impact. But the point is that, as Chris mentioned, that the positive predictive value is quite low. So if we all have these plaques and we try to stent them, then perhaps we have a lot of unnecessary stents. I think that having the first results from the preventing angioplasty studies will be quite exciting. And I think that perhaps some of this might be negative due to a low sample size, because drugs are getting better and better, so it's even harder to show an impact. And I also have a question for Chris. In the past, there was some skepticism regarding the fluorescence imaging, so the NIRF catheter, regarding the toxicity of the agents used in animals. And I think that one of the most interesting aspects of this kind of imaging was the one tried by Giovanni Ughi, who used the autofluorescence. So he did not use any agents, but tried to identify the signal. But after a very nice study, we did not hear much of it afterwards.
Can I have my slides, please? That's a very good question. The study of Ughi has a clinical translation, because you don't need to give the activatable marker into the patient. One thing I would like to say is that there are 2 histological studies showing that now we know what we see with autofluorescence. Because we said something lights up there, but we don't know what it is. It shows that we can detect spheroids. Spheroids is an important part of the lipid component, so it is associated with vulnerability and neovascularization. The role of neovascularization in causing events is not very well established yet. We don't have the evidence, but it seems that you can detect with autofluorescence features associated with increased vulnerability. The other that I would like to say is that they're trying to start now. I spoke to Farouk and Jaffer, who is the inventor of the study, and they're trying to start now, from what he was telling me, another study looking into the value of sorry, I would like to go through my last slide about that. Okay, so if you can have this on the presentation, that will be good. So, looking at the value of autofluorescence in terms of vulnerable plaque detection, they're starting a study shortly. For catepsins, the marker for catepsins, the IGF they have used for vulnerable plaque detection is FDA approved. And the FTP11 that I mentioned can also the potential of being FDA approved. So there is a potential for these markers to see them to the clinical practice in the future. You have to inject them half an hour before taking the patient to the lab. With regards to your comment about the vulnerable plaque detection, CT carries a great potential. We have trained with intravascular imaging, this for another presentation, CT for detecting vulnerable plaques, and there's a potential AI to improve vulnerable plaque characterization from CT. And what we can see in the future is you take to the patient, you do a CT scan, using AI or photocounting CT, identify plaques at risk, and with cumulative evidence, justify either an invasive sealing with emerging endovascular devices. Drug-coating balloon has been already alluded by Tom, is something that can be considered in these lesions, or even aggressive pharmacotherapy. Again, the Pacman study showed an increase in the fibrous cap thickness and reduction in the lipid component. So there may be an opportunity for personalizing care using combination of invasive and non-invasive imaging.
Well, from all this data, I think it's quite apparent that we have a long way to go, because you can see that all these are research efforts, even clinical research efforts, to identify the vulnerable plaque and which plaque will give events in the future. Professor Stutus has done a lot of work on this aspect as well. But of course, we have a long way to go. We saw that you use different markers for fibrin, for steroids, for whatever, to define better the composition of the plaque, then to see which plaque will rupture, then what event we will have, and then, after all, then at the end of the road, we have to demonstrate that by applying, let's say, the invasive approach, instead of statins, which will give anyway, it will make a difference. So we have a long way to go, but definitely it's a very, very important area, and I think we will see many evolution in the near future. Dr. Asnauridis, your comments for all the 4 talks.
Yes, thank you. I think we heard 4 great talks regarding the current status and the future of coronary imaging. About the first talk by Dr. Parikh, I have a question. I'm working in a busy public hospital. We're doing a lot of procedures, and in most of the cases we use imaging for the indications you mentioned, most of the times left main disease, stent thrombosis or restenosis, and to guide our procedure in the cases of severe calcification. So despite the data that coronary imaging improves outcomes, I have to admit that we don't use imaging in more than 15 or 20% most of the cases. So I would be very interested to know in what percentage are you using intracoronary imaging in your department?
Yeah, thanks for the question. The straight answer.
May I add, in other departments, UK as well?
Okay, yeah. I can't comment for all of the departments, but in our department, we're about 70% imaging, just under, yeah.
70?
Yeah.
70?
Yeah. Yeah, I try partly because I want to try and use them up. I'm 95% imaging now. There's only been 5 STEMIs that I haven't imaged in the last 6 months. I think across the UK the data is much lower, so it's 70% for left main and it's 25%, but it's still better than other parts of Europe, but obviously much lower than Japan. So that's that. I think that ultimately when the 1A recommendation comes, which I think will come, I think that we will all work harder to then bring it into practice. So in many ways, they come in parallel, don't they? The data comes, the guidelines then follow, and then we find a way to deliver it, and make it cost effective in terms of time and also in terms of training. And in fact, funny enough, I was speaking with Cleo earlier, it's not just the interventional cardiologist, as you know, it's the team, it's the cath lab time, it's the training. So it's quite a big multi-system organizational effort. But I think once the 1A recommendation comes, and I think we'll all work harder to get there.
Thank you. Regarding the second presentation, Leonida, great talk. You focus your presentation mainly on acute coronary syndromes, which is, I think, reasonable. I have the impression that imaging may be slightly overused in cases of stable coronary artery disease. I have several examples in my mind. I can remember several patients with atypical syndrome or even asymptomatic who have a positive stress test. Unfortunately, in our country, there are many patients who are sent for functional testing despite being asymptomatic just for screening. So, for example, a patient with mild inferior ischemia has an angiogram which shows normal circumflex, normal right coronary artery, and has a non-significant stenosis in the middle AD, which seems to be 30% in some projections, 50% in some other projections, and this patient ends up with intracoronary imaging, which I don't think it's entirely appropriate, because at the end of the day, this patient will be treated just with medication and risk factor modification. So what do you think? What's the role of imaging in stable coronary artery disease?
I think, thank you for your comment, Kostas. It's an excellent one. And we pass from the underutilization to the overutilization. Yes, for a patient like this, if we have ambiguities and great differences between the functional testing and the coronary angio, I would opt in for a functional testing in order to validate or cancel. I would use imaging if there is a visible ambiguity in many projections, or I have to quantify calcium in order to plan my procedure afterwards. I would then see imaging as the first step of my procedure optimization, the diagnostic step from the procedure optimization, except for left main.
Thank you, Leonidas. Regarding the third presentation, great presentation, Dr. Kibley. Before listening to this presentation, I must admit I was a bit skeptical about plaque characterization. First of all, because perhaps I don't know exactly how to do it in a very reliable manner, and second, because I don't know how to implement the information I would get into my patient. So I think I was glad to hear these two studies that you mentioned, the one with the preventive stenting and the other study with use of DCBs to modify angry plaques. So we're looking forward for the outcomes of these trials, I think. And regarding the fourth presentation, Dr. Bouradas, impressive technology, Christos. May I ask, what's the average cost of these fancy catheters that you showed us?
I mean, I have not come all of them. I think one by one. Cost of catheter 600 pounds, very similar to the cost of PS IVUS, a little bit more expensive than IVUS catheter. The Spectra Wave has just finished the first month study. They have not standardized the cost, but I believe that they are going to be at the cost of the OCT catheter in order to stay competitive.
Okay.
It's not the price the problem. The problem is the interpretation of the results and familiarization of with the technology. And because 1 minute, if I may, there is a problem to interpret the images in the cath lab. Abbott has done a fantastic work with software. These technologies are not there yet, and that will affect the penetration into the preclinical practice.
Thank you. Dr. Sandidas.
Thank you, Mr. President. Good afternoon. Thank you so much for the honoring invitation. Great session, expert speakers, and a novel meeting, I guess, for the Greek standards. So, taking the pass from Christos, I would like to comment on Dr. Parik's talk that there is now an applied methodology of how to perform actually intravascular imaging, even through acronyms that have been invented in Asian populations. And it's a good thing to know what we are doing in the cath lab. So we are looking always for the distal reference, the proximal reference, the lesion. We have to do all the right measurements. And I think this methodology will lead eventually to acute interpretations of everyday images, because this is also a major concern. We take the loops and we record videos and things, but do we know what they are saying, and we are accurate for this? Thank you.
Yeah, just a very quick comment. Do we have Ultron 2.0 in Greece, or does Christos? Do we have? We don't have it yet. So the Ultron, I totally agree with Christos's comment that actually bringing AI algorithms, or you may call them, automated algorithms, will really help. Instead of drawing the line on the ELs and really delaying the case, if you can see them quickly, you're going to make you're going to have a more efficient workflow. The labs are going to be more likely to use them. So, the Ultron 2.0, I don't work for Abbott, but it works very well indeed. You get the EL detection pretty quickly. You can apply the algorithms, and I totally agree with Christos. That's going to be very important. The other thing is the human factors side of getting the team to believe in it as well, and we talked about that earlier.
Okay. Any question from the audience or other comment? Well, if no, thank you, our